Ladies and gentlemen, welcome back after the lunch break. Next in line is the third symposium of the scientific sessions titled Exploring Obesity in Adulthood. Let me invite Professor Chandima Vikramatilaka, Department of Biochemistry, Faculty of Medicine, University of Ruhuna to chair Symposium 3. Over to you, Madam.
Good afternoon to all of you. We are starting with the third symposium of the day. So we have designed that symposium on a very important topic at the current context. So our first speaker going to be Professor Carol Lee Rooks. Professor Carol Lee Rooks is a professor of chemical pathology, University College Dublin, School of Medicine, Ireland. He completed his PhD at Imperial College of London and he received the President of Ireland Young Researcher Award from Science Foundation Ireland and Clinical Scientist Award from the National Institute of Health Research in UK and a Wellcome Trust Clinical Research Fellowship. He remains one of the cited researchers in bariatric medicine worldwide with a very high H index. In particular, his translational research on the understanding of the physiological role and pathological changes in appetite control and the impact of bariatric surgery on diabetes has been widely acknowledged. And in 2023, he was named as a Researcher of the Year by the Irish Research Council. That is a recorded speech, and that will be played now. Yeah.
Thank you very much for that introduction. My name is Carl Leroux. I'm a clinician scientist at work at University College Dublin. And my interest is to understand how to treat obesity as a disease and how we can help our patients who are currently living with the disease of obesity. And I start with this famous Renoir that depict these bathers, and you can see some of them have increased visceral adiposity, and you may be thinking that they have a sedentary lifestyle. And our purpose is to understand this disease better and to get away from the stereotype. But ultimately also, we want to turn our patients, such as those that you see in the background, who have a better quality of life, especially driven by functional gains, by improvement in metabolic health, but also driven by mental improvements for our patients. These are my conflicts of interest, and we work with lots of different companies, with pharmaceutical companies, with nutrition companies, and also with surgical companies, because we do not think, if we think about the state of obesity today, that we need one treatment. We probably are dealing with multiple diseases, and hence we need more than one treatment. So I would like to advocate for more nutritional therapies, more pharmacotherapies, and also certainly more surgical therapies. But what I would not suggest is what we see on the right-hand side, which is our famous Greek character Sisyphus. And you may remember that he was thrown into the depths of Hades, and what he had to do was roll up this rock, up this hill every day. And every time he got to the top of the hill, the rock would roll down and he would have to start all over again. And this is what we've asked our patients living with obesity to do. We ask them, in good faith, I will add, but we ask them to eat less and to move more. And of course they can do that for a period of time. But at some point, they just become hungry again and start eating. And that's the equivalent of the rock rolling down. So what I would like us to do is understand obesity as a disease so that we can remove the rock. so that we don't have to ask our patients to do things above and beyond what is possible for mankind, but rather to think about how we can help them to manage this disease process in a more sufficient way. Now, if we just look back at the physiology, what we understand is that the gut talks to the brain, and it uses different mechanisms. You can see the neural signals from the vagus. You could also see some of the hunger hormones such as ghrelin, or the satiety hormones such as PYY, GLP-1 or oxyntomodulin. Of course, we also know that adipocytes signal, through leptin. But ultimately, the signal goes to the central part of the brain. So we think about this as the subcortical areas of the brain. Now that's an important factor because for a very long time, we have not understood which organ it is that we are treating when we treat the disease of obesity. We may have looked, for example, at the adipocytes because there's a lot of evidence to show pathological adipocytes in people living with obesity. Or we may have looked at the gut as a point of where some of the signals are generated. But I think what is becoming clearer is that many of the diseases of obesity that we are treating are focused on the subcortical areas of the brain, or at least that is a common pathway for many of the diseases. And hence, if we understand, at least even if it's just philosophically, understand that what we are trying to do is to address a subcortical brain disease in many of our patients, then it's going to help us have sympathy with ourselves because it's hard to treat subcortical brain diseases, but we'll also have more sympathy with our patients when it comes to the challenges of how difficult it is to do this. Now, of course, the gut is an amazing place and probably one of the largest endocrine organs. And here I'm just listing all the gut hormones and when they were discovered. And so every time you and I have a meal, we have a perfect dynamic function test because we are releasing some of these hormones in different proportions, or when we become hungry, our gut changes signaling. So therefore, understanding how the gut works is a really good place to start when it comes to understanding obesity as a disease. And we can maybe utilize some of these gut hormones to the advantage of our patients. So we're going to look at different strategies, how that can be done. Now, of course, one of the strategies that we've had for the last 50 years that has worked really well for the last, half a century, would be bariatric surgery. And here I'm just showing you the two most common treatments that we have today, the gastric bypass and the sleeve gastrectomy. But if you think back, 50 years ago, if you had a gastric bypass, you would have lost exactly the same amount of weight than what you would lose today with a gastric bypass. So we haven't made the bypass better over the last 50 years when it comes to amount of weight loss or even health gain. But what we have certainly done is improve its safety. Today, this is one of the safest elective operations you can have, in the abdominal area. And the safety of the surgery today is really a testament to our surgical colleagues and how they've improved their own procedures. And I want to congratulate them. But yet, it's still one of the barriers because many of us as internal medicine doctors or even patients think of surgery as rather unsafe or with a lot of problems. But in fact, these treatments are now very safe and very effective, as they've always been. But if we compare that, for example, with some of the medications, and I'm just highlighting two of the recent medications, liraglutide and semaglutide, we can see that these two drugs, have 97% homology or 94% homology in the case of semaglutide to native GLP-1. Now, when we are thinking about surgery, bypass or sleeve gastrectomy, and how it elevates GLP-1 threefold, it may not come as a surprise to you that when we give pharmacological doses, that some of the effects that we are seeing may be similar. Now, clearly there are differences, and we're going to emphasize some of those differences, but I also want you to understand that it's the same signaling pathway that we are using in these cases. Now, the big challenge that we've had with surgery was thinking about how do we use this in a modern paradigm where we have more effective medications available. And this is the microvascular outcome of metabolic surgery study, the MOMS trial done by Ricardo Cohen. And I think this is the way forward, where we think about what Ricardo did is he took 100 patients who all had type 2 diabetes, BMIs between 30 and 35, but all of these patients had complications of diabetes. They had diabetic kidney disease, as evidenced by the raised urine albumin-creatinine ratios. And what he did is he randomized them to base medical care, because our base medical care has improved dramatically when it comes to diabetic kidney disease, or surgery plus base medicine. And I think that's what we're going to hear more often. I think that is going to reflect the state of the art as we move forward, is it's not surgery against medicine or nutritional therapies against pharmacotherapy. It's how we can combine these treatments to the benefits of our patients. Now, let me just outline, for example, the best medical treatments. Here we combined, those best drugs that we have for diabetes today, the GLP-1 analogs, the SGLT2 inhibitors, but also with metformin, where we needed ACE inhibitors, statins, diuretics, etc. But compare and contrast that with the surgical arm, where patients had a gastric bypass, but they were maintained on their ACE inhibitor. They were maintained on their statin and their metformin and their multivitamins. So you can see, of course, far fewer medications may be needed when you've used surgery, but it's not sensible to stop those treatments that have shown to have benefits when it comes to cardiovascular mortality. Yes, we can reduce the doses of the ACE inhibitors and the statins very often, but actually maintaining some of those benefits by continuing the medications may be very valuable. So here's the 5-year outcome study. And what we can see is that if we just look at remission of albuminuria, so those patients that achieved an albumin-creatinine ratio below 30 milligrams per gram, what you will see is that base medicine today were far better than we anticipated when we set up this study. So remember, all of these patients had raised urine albumin-creatinine ratios at the start, and you could see even at 5 years, almost 60% of patients with base medicine were in remission. Compare and contrast that to the surgical arm, where approximately 70% of patients were in remission. And if you look over those 5 years, you can see at 2 years, surgery outperformed medicine. But at 5 years, if we just look at remission, then surgery and base medicine were equivalent. Now, if we go one step further and we look at urine albumin-creatinine ratio as a continuous variable, we can see that both the treatments, base medical treatment as well as surgery, were very effective. But that surgery was more effective than base medical treatment. So just getting to remission, there's no difference. But if we look at it as a continuous variable, we see that the combination of surgery plus base medicine certainly is very effective. Now that also gives us a lot of hope, because it means that we can turn the clock back. We know that we can put diabetes into remission with substantial amount of weight loss. But now we have evidence to show that even diabetes complications, such as diabetic kidney disease, can be put into remission with a combination approach. So if we think about chronic kidney disease as remission, we can see that the best medicine, is very good. Base medicine with surgery appears to be, as good, if not a little bit better. And if we now look at weight loss, what you could see is that surgery plus base medicine outperformed base medicine substantially. So that amount of weight loss that we see, 40% of weight loss is very impressive. But I also want to draw your attention that there is a small number of patients, even with surgery and base medicine combined, that lost less than 5% of their body weight. Now, that is rare to happen, but it does happen. And it allows us to understand that there are responders and non-responders to all our treatments. Now, you'll also remember that these patients all had BMIs between 30 and 35 to start with. But if we look at the number of people who achieve more than 15% weight loss, and that's the amount of weight loss that we think we really need to reverse complications of diabetes and even drive cardiovascular benefit, we see that more than 90% of the surgical patients that were combined with best medicine achieved this threshold. No patient in the best medical treatment arm achieved a body mass index below 25, but in the surgical arm, more than half of people achieved this BMI below 25. And I think this is going to be another, state of the art in the next 10 years that we will have to think about. Because up to this point, when we treat obesity, we've always focused on percentage weight loss. But if we think about how we treat other chronic diseases, for example, hypertension or dyslipidemia or diabetes for that matter, we treat to target. But in obesity, we've never had a target, and we've also didn't have a treatment approach that could get patients to target. But I think this is something that is going to change now. And what this study shows is that if we make an arbitrary target of a BMI of 25, more than half of the patients could achieve that. Now, it is true that we may change our minds. We may change the target. It may not be 25, it may be 27, or it may be 30. We are not sophisticated enough to work that out. But again, if we think about type 2 diabetes, we constantly are revising our targets as new evidence arrive. But at least we are approaching a target with our treatment. I think this is going to be something that we're going to do much better in the future when we treat people with obesity. Glycemic control was, of course, much better with both treatments, but specifically improved with the surgery plus best medicine. And I think this is another important point, that we can put diabetes into remission, but we want to keep it in remission for 5 years. And how are we going to do that? And I think the way is going to be with a combination of pharmacotherapy. And if we think about the ADA target of a hemoglobin A1C of less than 6.5, we can see more than 60% of patients achieve that. Now remember, these patients had long-term type 2 diabetes. They had complications of type 2 diabetes. So these are not the patients that readily goes into remission and stay in remission. These are the people that go into remission really in a rarity. But we can see that it's achievable when we combine it with medication. Blood pressure changes, again, no difference in systolic blood pressure because our treatments are so good. But certainly what we see with surgery is that it decreased diastolic blood pressure and reduced the doses and number of medications that we needed to achieve these improvements. But it's when it comes to quality of life that I think there's a couple of salient points that we have to, understand. Let's look at the graph at the bottom, the 60 months follow-up. So first of all, what we can see is the functional domain, the physical health of people improve dramatically when it comes to the surgical above the best medicine. But on the mental health domain, there was no differences between that. But it's the functioning, it's the general health and the physical role functioning that we see that is associated with this 25-30% weight loss. That is not to be underestimated. And when speaking to patients, they often have the biggest value that they attain by the functional improvements. So don't forget about that, that's really when we listen to the patient voice, what do people find helpful? They really talk about these functional gains as very important to them. So what were the adverse events when we are thinking about the MOMS study? So first of all, there's some people that say surgery is very unsafe. And we should be worried about that, especially in patients with diabetic kidney disease. Other people say, we don't know about the long-term side effects of these medications. Here we can see what happens after 5 years. And you can see that both treatments, the surgery plus the best medicine, have been tolerated very well. And we are able to manage that without major problems. But especially, I think it's important to say that the surgery was very safe and no different to what we see, with the best medical arm. But that's not because best medicine wasn't safe. Both treatments are safe. Both treatments are very well tolerated. So let's now change tack and think about, alternative approaches. And I want us to go forward in the future and differentiate two ideas. We are talking about obesity treatment on one hand, and on another hand, we are talking about calorie restriction. And I think these are two very different approaches. So we've seen with base medicine as well as with surgical treatments, we can see obesity treatments. Let's now look at the opposite of obesity treatments, which is calorie restriction. And this is illustrated by the Biggest Loser experiment. You remember that patients for 30 weeks were asked to lose as much weight. They were driven by doing lots of exercise, calorie restriction. And of course, what happened is they were very successful. But let's now look what happened to them 6 years later when the same patients were studied. So what we see on the left-hand panel is that initially from baseline, patients weighed about 150 kilograms, and with these draconian measures of calorie restriction, they were coming down to approximately 90-95 kilograms. A lot of weight loss. But see what happened at 6 years, the patients regained most of the weight. Now, if we look at the middle panel at the resting metabolic rate, what you can see is there's an initial reduction in resting metabolic rate. But look now what happens even when people have regained their weight. Their metabolic rate does not recover. And therefore, on the far right-hand panel, when we think about metabolic adaptation, it appears to us that we have harmed our patient. And remember, the first rule in medicine is do no harm. So if you have a calorie restrictive approach, what you may end up doing is harming your patient by really detrimentally affecting their metabolic adaptation. So let's think about this in the following terms. If you have a person living with obesity and you give them calorie restriction, and I make the point, this is not obesity treatments, this is calorie restriction. If you do that, what you'll do is you'll make the person weigh less. But what you would have done is you would have created an energy gap. The patient will become hungrier, and the patient will have a reduction in energy expenditure. So you've really helped this patient from the pan into the fire. So when we give patients a nutritional therapy or an exercise therapy that's not calorie restriction, but rather treats the disease of obesity, what we see is that patients also can lose weight, but that these factors, this increase in hunger, reduction in energy expenditure, are significantly attenuated. And I think we're going to come back to that to help us understand when are we calorie restricting a patient and when are we treating the disease of obesity. So let's look at some of the pharmacological treatments. So here I'm showing you the step 1 study, and you'll remember this is with semaglutide, 1,961 patients randomized 2-to-1 to either having placebo or semaglutide 2.4 milligrams. And what you'll remember is that patients lost approximately 16% of their weight on average. But I want to focus you on the graph on the right-hand side. This is remarkable. A third of patients lost 20% of their weight. This is incredible, how effective this treatment can be. But I also want to focus you on the left-hand side of that graph. And you can see that 8% of patients lost less than 5% of their weight. So they either gained weight or didn't lose much weight. Now, important to note that it is not the smart people that listen to you or me that go on to lose 20% of their weight, or the people that don't listen that don't lose weight. It is biology. And it's important, especially in this era where we have highly effective second-generation medications for obesity, that we don't forget about those patients that don't have a biological response. That we think about how are we going to help those patients in the future. Now, one treatment that we may also consider in the future is a combination approach, and tirzepatide combining GIP and GLP-1 may certainly be something that we want to think about. And again, the amounts of weight loss that we have seen has been remarkable. Here we see 22% weight loss on average in our patients with tirzepatide 15 milligrams. But it's again when we look at the categorical weight loss, here we see more than 39% of patients losing more than 25% of their weight. incredible amounts of weight loss. But again, focus on the left-hand side that there may be 4 or 5% of patients that don't lose weight. Again, really fascinating how this treatment can have such a difference in response in individuals. And again, I want to emphasize, I have seen thousands of patients with obesity, probably very similar to you, but I have zero ability to predict how much weight a person will lose prior to us starting. So I can predict if a patient will be compliant, or I can predict if the patient is going to be pleasant to look after in the long term, but I cannot predict their biological response. And I think that's also going to be a state of the art that's going to change for us in the future, is are we going to have these predictive tools that we will be able to say to person A, look, I think you should really be having surgery because you may not respond to medication. And patient B say, look, you are predicted to have an incredible response with these medications. I think this is something that we need to try first. So this is something that I think we need to remain humble about, that, yes, we have improved dramatically, but there's so much more we have to learn. And one of those being, how can we predict? Now let's just break this down. And the top graph is the placebo arm. And I want to draw your attention in the gray on the far right hand. There are patients that actually lost a third of their body weight with placebo and lifestyle changes. So it also shows you that lifestyle changes work. It works in a small percentage of patients. I think about 2 in 10 patients will have a sufficient response for an obesity treatment that involves lifestyle change. So it certainly does work. But we can see that there's also patients that gained weight with this treatment. But let's now look at the bottom part. And here we're looking at the patients with tirzepatide. And you can see on the left-hand side, it's the patients who gained weight. On the right-hand side, patients who lost weight. But focus on the bottom blue. So first of all, you can see that 97% of patients lost weight. There were some people that lost half of their body weight with 15 milligrams tirzepatide. Also meaning that in future, we may not have to use the top dose for every individual. We may have to be able to reduce the dose, because if somebody has a body mass index of 27, and you treat them with tirzepatide, you certainly do not want them to lose half of their body weight. So therefore, you may want to use a lower dose of the medication and get them and treat them to target. But I also want to focus on those patients on the left hand, where even people with tirzepatide gained weight, despite them taking this medication. So I think that's important when we think, yes, it's very small numbers, but these are individuals living with obesity. And you can imagine how you will feel if you have this incredibly effective treatment that does not work for you. You will feel like a failure. And of course, many of the people that will engage in your treatment will be bewildered. How is it possible that you take this highly effective treatment and gain weight? There must be something wrong with you. So we must be very clear that we reduce the stigma of obesity, and especially the stigma in those patients that do not respond to our highly effective treatments. That is going to be important. Now, why do these treatments work? Because when we measure the symptoms of obesity, and I think they are excess hunger and reduction in satiety, what we see with these treatments do, if it's semaglutide or tirzepatide, we see a dramatic improvement in these symptoms. And that's what patients tell us initially. They say, doctor, this is incredible. Because since I've started this treatment, I don't feel hungry, I feel more full, I'm not thinking about food all the time, I'm eating smaller portions, but I enjoy the food that I'm eating. And that is why these treatments are sustainable. I think, and I'm going to start summarizing, by the state of the art today is that we're moving away from this idea that it's energy in and energy out. Here I'm showing you my house. And what you can see is the temperature in my house is not controlled by the very good boiler that I have in my house that generates the energy in, or the very good windows that stops the energy out. In fact, the temperature is controlled by a thermostat. In my house, it sits in my kitchen, and I decide if my house is going to be 20 degrees Celsius or 25 degrees Celsius. Now, if I turn the temperature from 25 down to 20, what happens is my boiler stops working because it's not pushing energy into the system anymore. But the minute my house reaches 20 degrees Celsius, the boiler starts working. And that also explains what we are seeing now when we are treating our patients, that when they are losing weight, when they're coming down from the 25 Celsius to 20 Celsius, they're not eating, they're not feeling hungry, they are really feeling satisfied at a small amount of food. But when they reach that new homeostatic point, the 20 Celsius in my house, the boiler starts working again, then they start feeling hungry, they start eating, and we have to reassure them that this is normal physiology. This is not an indication that the treatment isn't working, but in fact, this is normal physiology. So where are we focusing our treatments? I'm highlighting the hypothalamus here, but I'm really referring to the subcortical areas of the brain, the area postrema, the nucleus tractus solitarius. So this is where we are focusing our treatments. And if it's a nutritional therapy, a pharmacotherapy, or a surgical therapy, this is where we're going to have most success when we treat our patients. Because ultimately, if we have a nutritional therapy, pharmacotherapy, or surgical therapy, we know we are successful when the patients come back initially and say, you know, I'm feeling less hungry, I'm feeling more full, because we're working through this common pathway that probably sits in the arcuate nucleus to ultimately reduce appetitive behavior. This drive that our patients have to seek food and to eat until they feel satisfied, but this can be reduced by effective obesity treatments. So how will we achieve this? I think we need to treat obesity in the same way as we treat any other chronic disease. And yes, we need to have a hierarchy of how we go through the steps, but also we need to have individualized treatment. So I think a patient can enter at any point of this hierarchy, but it allows, this is a framework of thinking for us that allows us to move our treatments forward. So we need more self-directed lifestyle changes. We need more public health messaging. And it's not prevention against treatment. It's prevention with treatment. We need to do both of these things together. And it's not a choice between one or another. We certainly need more professionally directed lifestyle changes, and this is where nutritional therapies and exercise therapies are critical for the treatment of the disease of obesity. I want to emphasize this again. This is not calorie restriction. This is obesity treatment using a nutritional therapy or exercise therapy. We know it is safe. We know it can be very effective. We know a smaller number of people respond to it. And if people do not respond, then we won't stigmatize them, but in fact, we will escalate them to consider obesity medications. And this is where the biggest growth area is going to take place, because these treatments are scalable. And that is what's going to change for us in the next 5 years, is having scalable, effective treatments that we can use. But a large number of patients may not respond to our medications or may not want to have medications, and they may be appropriate for bariatric surgery. So I do not think that we'll do fewer operations in the foreseeable future. I think we're going to increase the number of bariatric surgical procedures that we need to do, because we're going to engage in more patients engaging in treatment. So therefore, if we have people who engage in treatment, who do not respond to our nutritional therapies or pharmacotherapies, then we need to escalate them to very safe and effective bariatric surgery. But even in people who've had bariatric surgery, there may be non-responders, and therefore we need combination therapies. And if you look at this looks exactly the same than any other chronic disease that you and I are treating, and therefore it makes it easy. And I'm actually saying to our residents now and the fellows, I say to them, if you've got a question, what should I do with this patient, who's living with obesity? I just turn the clock back and say to yourself, if this person had hypertension, what would you do next? And just thinking about obesity in that same mind frame and that same philosophical approach allows you to know what your next steps are. But what we haven't done is we haven't put obesity in this box of chronic disease care, and this is what we now need to do. I think projects such as the IMI Sophia, that's finding the predictors of risk and the predictors of response, is going to make a big difference to us in the future. So let me conclude and suggest that obesity is a complex and chronic set of diseases. It's characterized by excess adipose tissue that causes a deterioration in health. Multiple and diverse diseases can result in this excess adipose tissue, and a unifying diagnostic criteria may be challenging at the moment. But we can now engage in treatment, be it nutritional therapies, pharmacotherapies, or surgical therapies. But remember, not all forms of obesity require treatment, but treatment should always be focused at health gain. Our objective is not weight loss. Our objective is ultimately health gain. Please allow me the team at home that's doing all the hard work, as well as our international collaborators. Thank you very much.
On behalf of the Nutrition Society of Sri Lanka, I would like to express my heartfelt gratitude to Professor Carol Lee Rooks on his very informative lecture. Before moving into the other two lectures in the symposium, I would like to inform the audience kindly to stop pocket discussions and also answering phone calls that would distract the speaker and also that would disturb the other listeners. So to proceed with the symposium, I would like to invite the two speakers who are in person to the head table, Professor Atula Sumathipala and Professor Ranil Jayawardena. Our next speaker is going to be Professor Atula Sumathipala. He was graduated from Faculty of Medicine, University of Colombo with his MBBS and obtained his qualifications as a family physician, a diploma in family medicine and MD. And he was retrained as a psychiatrist in the UK and obtained his MRCP psychiatry and specialist training. And then he earned his PhD at University of London. Currently, he is the director of the Institute for Research and Development and the chair of the National Institute of Fundamental Studies, Hantane in Sri Lanka. He is an emeritus professor of psychiatry at the School of Medicine, Keele University, and an emeritus professor of global mental health at King's College, London. He is a member of many editorial boards of many international journals, and he is having a lot of publications to his credits, and he's an internationally recognized researcher on cognitive behavior therapy for the treatment of medically unexplained symptoms and chronic diseases, and also he is an expert in bioethics. He established Institute for Research and Development in Sri Lanka to promote the research, and he created the Sri Lankan Twin Registry. And on my personal note, he's a multitasking, very persuasive researcher. Over to you, sir, to proceed with your talk today on the impact of obesity on psychological well-being.
Chandima, for that kind introduction, and also thank you for giving me this opportunity to share with you some of my expertise and managing this difficult group of people. I'm also very grateful to the previous speaker who actually set my task very easy by his last slide, coming up with a sort of overall intervention strategy with hierarchical treatment, in which he very clearly mentioned the role of other things which need to be done other than the surgical treatment. So the outline of my presentation would be, I would talk to you very briefly about the sort of background, then share with you psychological and mental health conditions associated with obesity and the psychological impact on weight loss, not only gain, mental health interventions for obesity, implications for surgery, the role of assessing psychosocial functioning, the role of psychosocial interventions, and introduction to personalized. See, the previous speaker mentioned about the need for personalized, tailor-made treatment, but using cognitive behavior therapy, which I will sort of concentrate a little bit more, because all the nutritionists can. You don't have to be expert in cognitive behavior therapy, or you don't have to be a medic to do that. So we all know that to the core of anthropometry, we deal with weight. We talk about body mass index, but I want to highlight this fact that the issue of obesity is beyond anthropometry or body mass index, because there is reality versus perceptual body image, body dysmorphia, the social media, and how people think about it, attitudes resulting from behavior. The speaker mentioned also about the stigma. So we take the person as a person, whether they are obese or overweight. So the results from complex interactions coming from the obesity results from interactions from multiple genes. It's not any single gene, and environmental factors. And it's very important to understand the relative contribution of genes as well as environment, particularly the adding the attitudes, stigma, the way people think about it, the way media talk about it, what are the cultural expectations, etc. Studies of monozygotic and dizygotic twins have very clearly shown that there are much greater resemblance in the degree of obesity between genetically identical monozygotic twins, which indicates that there is a genetic component, but it's not the only thing. So this is actually I'm the Secretary General of the International Society of Twin Research. We have pooled data from 66 twin registries, thousands of people, hundreds of thousands of people, and very clearly shown that, the central obesity has a relative genetic component as well as environmental component. So that's why the role of cognitive behavior therapy is definite place. And again, which complicates this, obesity has other comorbidities as well, as the speaker highlighted. It's associated with cardiovascular disease, type 2 diabetes, osteoarthritis, many things. So therefore, with these comorbidities, the significant psychological burden, it's very difficult to attribute only to obesity. It's multiple, there's confounding. So therefore, you have to take it into the holistic picture in the management. So these are two twin studies we have done in Sri Lanka to show that again, central obesity, and again, this particular one which shows, I'm sorry about the focusing or the quality of the papers, the psychiatric morbidity is very significant, but you can't say whether it's only because of the obesity or whether due to other chronic diseases. Psychological mental health issues of people with obesity, I just want you to concentrate on this. All of us feel sad at some point, but that can change either in quantity and quality, which become a symptom of depression, misery. So when people are obese, they may have normal sadness based on what other people comment about them, what the social perceptions are, or they may have misery, depression. So it's a continuum. It's same with anxiety. So be mindful when we talk about mental health associations. We are not necessarily talking about mental illness. It could be a normal psychological reaction to who they are. Then psychological and mental health issues of persons with obesity could be emotional distress, as I told you, not necessarily a mental health diagnosis. Anxiety disorder. Low self-esteem, which is not a mental health issue as such, but how they perceive about themselves. Then mood disorders, particularly depressive illness. Then eating disorders, substance abuse, quality of life, the speaker mentioned about, and the perception of their own body image. So when it comes to depression, research has clearly shown a relationship between body weight and depression. Persons with extreme obesity are 5 times likely to have experienced an episode of major depression during the previous year. It's an association, you can't talk about a causative relationship. Compared with the normal people, relationship between obesity and depression is stronger for women. Again, research is not very clear why that is, maybe partly because of the perception that a thinner person is more beautiful, in certain cultures. 1/3 of candidates for surgery reports clinically significant symptoms of depression at the time of surgery. They have a 50% report a lifetime history of depression. So that's again an association. The reasons for this high prevalence, not very clearly understood, may be related to stigma and discrimination. Not necessarily because they are obese, but the impact of stigma and the discrimination they face. Then again, eating disorders is common among people with obesity, particularly binge eating. When you say binge eating, that's related to emotional reasons, having difficulty in controlling the frequency, the portion, and also influenced by bombardment of food cues from modern society, the television. Minority have, again, binging disorders, which I said. Then smaller percentages have bulimia, the other extreme of anorexia. So all these are part and comorbid attributions of obesity. Anxiety, normal anxiety, they are anxious, which is a protective mechanism. So therefore they may not eat excessively, or they could become as a patient with mental disorder of anxiety. Anxiety disorders are common among patients with surgery. The occurrence among these presenting for non-surgical treatment is less well established. The most common anxiety disorder in candidates for bariatric surgery is social anxiety disorder. In the light of Western society emphasis on thinness as a marker of physical beauty, people with extreme obesity report increased anxiety and even social isolation. And social anxiety, unless crippling, is not a contraindication for weight loss treatment. Uncontrolled anxiety may negatively impact engaging on treatment as well. So then again, substance abuse, a small minority of people with obesity for weight loss treatment actively abusing substance. Active users or abusers is considered a contraindication for weight loss treatment. If somebody is, then first you have to treat that before you get on to any engagement. Approximately 10% of candidates for bariatric surgery report a history of illicit drug use and alcoholism. Now, psychological impact on weight gain. Weight loss is typically associated with improvements in the psychological state and functioning. These positive changes are often profound among those who have lost a large percentage of their weight, understandably, as is often seen in bariatric surgery. Some individuals who lose weight experience return of pre-existing psychopathology or development of new psychosocial issues. So surgery may not necessarily change their psychiatric morbidity, partly because of the other associations as well. Those who experience weight gain, regardless of the approach to weight loss, whether it's pharmaceutical or psychological or surgical, also remain at high risk for return having unwanted psychological symptoms. So they are still vulnerable. Having said all this, therefore, all treatment providers should be mindful to assess psychological functioning at the onset of treatment, monitoring change during the weight loss, and remain alert for worsening of symptoms with weight gain again. This is my take-home message for the audience here. Be mindful. Engage them right at the beginning. Monitor. And sometimes people with depression may also get suicidal ideations, not necessarily completing suicide, but be mindful about that as well. So the mental health interventions for obesity, particularly the implications they have for surgery. Many with obesity seek mental health treatment to modify their eating habits or address the emotional consequences of the disease before coming to surgery. I don't know what's the situation in Sri Lanka, but this is in the Western countries. Approximately 50% of candidates who have surgery report a history of mental illness, as I told you, and 40% report having taken treatment, either psychotherapy or pharmacotherapy, again abroad. Use of psychiatric medication, particularly, this has, you have to keep in your mind very carefully, particularly antipsychotics and antidepressants can contribute to weight gain or negatively impact on weight loss, because those two have weight gain effects. So little it is known about the medication interaction with different surgical procedures. Changes in absorption of the medication may occur after surgery, and there may be, many other reasons for that. Now, body image dissatisfaction. Now, weight loss is typically associated with improvement in body image, self-perceived. Unfortunately, some patients lose large amount of weight, report most typically after surgery. Residual body image dissatisfaction with their loose, sagging skin of the breast, abdomen, thighs and arms. So they come up with new psychological issues secondary to surgery. The most surgical people who have gone surgery consider the development of excess skin to be negative consequence for surgery. This dissatisfaction is likely motivates individual to present to a plastic surgeon then for body construction procedures. Again, I don't know what's the situation in Sri Lanka. So there's essential role of assessing psychological functioning, as I told you. Evaluation of psychosocial functioning is an important part of the assessment and treatment planning, particularly in the case of surgery, before surgery. Although weight loss is associated with improvement in psychosocial functioning in most individuals, a small number of patients experience, as I told you, psychological symptoms after. Now, this is the most important bit in my talk, the half. I'm going to keep to my time. The role of psychological interventions. Now, it's the personalized cognitive behavior therapy for obesity. I want to concentrate on this. Cognitive behavior therapy is a big word, but it's a very easy thing for all of you to learn. In a culture like Sri Lanka, it's very easy because I'm sure you have heard about Kisa Gautami. She went to Lord Buddha with her death child asking to give the life back. But then Lord Buddha said, go and bring some mustard seeds from a house where nobody died. So the Lord Buddha used a behavioral strategy. The patient went from place to place, not patient, Kisa Gautami, and realized that there was no house where nobody was dead, thereby changed the way she thinks. In our technical jargon, we say cognitive restructuring, which changed the way she feels. So it's a triad, I'll come to that. So personalized cognitive behavior therapy is a new treatment that combines the traditional procedures of standard behavioral therapy for obesity. Self-monitoring, goal setting, self-control, contingency management, behavior substitution, skills for increasing social support, problem solving, and relapse prevention with a battery of specific cognitive strategies and procedures. Ogalan katawa natanna puluwan please. Mama distract වෙනවා. හරි කතා කරන්න එපා please. These enable the treatment to be individualized and help patient to address cognitive processes. I'll tell you what the cognitions are that previous research has found to be associated with treatment discontinuation, the amount of weight loss and long-term loss maintenance. So there's a paper you can read. Now, cognitive behavior therapy is effective for most chronic diseases. In fact, I worked at Royal Marsden, which is a tertiary cancer hospital in UK, where we had a cognitive behavior therapy department which used to give cognitive therapy to patients with cancer, along with psychotherapy and radiotherapy. And the longevity, quality of life, everything was much better. And you can use metaphors in delivering CBT. It's very, very easy to do. So I have developed certain metaphors. I'm not going to go into details. This paper is available. For an example, we talk about, even with obesity, automatic negative thoughts of people. So when you say automatic negative thought, that's the technical jargon. The metaphor I develop is rubber ball under the water. Anybody will understand when you say as a rubber ball under the water, it doesn't need any effort for the ball to come up. So you are very preoccupied about the weight and the stigma, what people comment, ayyo, mahatai ne, mokada me kanawada. That type of thing. You go for a wedding, you go for a funeral house, ayyane me mahattela aisa hari lassanai ne, dan ane mokada me kata wela hondareyak wage, that type of. So that's, the thoughts come up, automatic. And they continue like you driving towards a cliff. If you drive towards a cliff, you fall. So what you need to do? Put brakes, thought stopping in CBT technical jargon, distraction, take a different turn, or go back, challenge your automatic thoughts. So the cognitive behavior therapy, last quarter of my talk, central to the cognitive behavior therapy is that the patient's cognitions, I'll tell you what they are, of primary importance in determining their emotional state, physiological state, which is important again in obesity, and behavior. So instead of being concerned about the possible causes of the illness, whatever it is, type 2 diabetes, rheumatoid arthritis, CBT focus on teaching people how to control their complaints of disturbed emotions, thoughts, and behaviors. So what are the cognitions? The beliefs, assumptions, and thoughts. You have certain beliefs about food, what to eat, what, makes somebody beauty, how you eat. So there are a lot of assumptions, beliefs, and thoughts which are influenced by stigma, what you believe, the social advertising, many different things. So therefore, we use techniques, what we call cognitive techniques, for restructuring the way they think, like Lord Buddha did with Kisagotami, to restructure the way they think about death. So similarly, you can use cognitive behavior therapy to restructure their thoughts about their body image. And the previous speaker said, everybody doesn't need treatment. And sometimes your body, the overweight, is not necessarily reaching the level of obesity. You don't have to go for surgery. But Sriyavati or Kamalavati on the other hand said, so then identify the negative thoughts associated with all these, deal with the negative thoughts, and consider alternatives. It's a very effective thing. And the behavioral techniques are distraction. If you are a binge eater, you use distraction techniques. Activity monitoring, scheduling, goal setting, set targets, exposure and response therapy. You go to a wedding, you get exposed to huge amount of food. Response prevention, you don't eat everything. Equally important for even for type 2 diabetes, whatever it is. And you make a contract, the therapist make a contract with the patient for weight reduction. So what is cognitive behavior therapy? Is intervening with this triad, behaviors, thought, and feelings. They are interlinked. The way you think determines how you feel and you behave. And there are core beliefs about self, other people, society. So you deal with these cognitions in a way using different techniques, analogies. That paper will give you a lot of analogies, generic analogies which you can use for anything. So one of my analogies is for thought stopping. You drive towards a cliff, you will fall. What would any sensible driver would do? Stop, brake. So if you allow your thoughts to progress about, how you were criticized by somebody at the wedding, this, that, you will end up, feeling very low self-esteem. You cry, you hate the person who told you that. So you put brakes, you distract, you challenge your own thing. So who cares, That's my body. I don't care, I'm not obese, I'm not fat. I don't have to have surgery because That type of you challenge and you change the way you think. So because it's a triad, you can use interventions, cognitive and behavioral techniques to stop. It's in a very simple sense. So I'm not going to talk to you in details. I mean, just wanted to give an outline and particularly convince you that at the very beginning, when somebody comes to you, do a very, very clear assessment, psychological assessment. Think why they think about their body image. You know, everybody who are fat, it's a continuum as I showed you at the very beginning. Some people are very thin. They may have become very thin deliberately because they are ballerinas or models. අයියෝ මොකද මේ කෙට්ටු වෙලා දැන් ගිය සැර දකින්නකොට වගේ මේ පඹේක් වගේනේ, right? Or the other way. So assess, see how they think. Everybody is not having mental illness, psychological reactions, think the way they think about their body image, food consumption, all that, and be very careful in referring them and managing. It's a holistic management, as the previous speaker said. And cognitive behavior therapy, along with other therapies, has a place in the management of people with obesity. If anybody wants to know more about it, please get my email address from Chandima. We do a lot of training with cognitive behavior therapy. We have workshops. We can help you all. And my plea is, remember, as a nutritionist, you have a big role to play, and you can be learned. A lot of these, I didn't go into details. In our trials, we offer 6 sessions. People only come for 3 sessions. They get better, even for depression and many chronic diseases. It's a very effective type 2 diabetes. For compliance with your medication, yes, CBT has a role. Change the way lifestyle, the speaker mentioned, CBT has a role. And I'll stop there. Thank you very much for giving me this opportunity to share some of these thoughts. I just want to infect you with the cognitive behavior therapy. That was my task. Thank you very much.
Thank you very much, sir, for your thought-provoking lecture. I know that you are very busy and having very busy schedules. Thank you for accepting our invitation and giving this talk. And our next speaker is Professor Ranil Jayawardena. I think he doesn't need any introduction to this community, but still, as a customary, I will introduce him quickly. Professor Ranil Jayawardena is a medically qualified clinical nutritionist. He received his medical training from Faculty of Medicine, University of Colombo, and he followed his MSc in clinical nutrition from University of Glasgow and PhD in nutrition from Queensland University of Technology, Australia. And he is a renowned scientist in the first topping the he has topped the world famous scientist, and he is having many publications to his credit. Over to you, Ranil.
Thank you, Professor Chandima. And first, I must thanks for the President of the Nutrition Society and Organizing Committee for inviting me. Today's topic is dietary strategies, obesity management. This is a kind of pet topic for me, and probably many has heard this topic also from me. And there are few conflict of interest I have to declare. So, because I will show some plate concept, which is something authored by myself, and we use a meal replacement for one of study, which also designed by myself. So there will be little bit of bias for my data, but otherwise there are no other conflict of interest regarding this lecture. Most of the time we discuss about weight loss, and even previous first week also discussed weight loss with surgery and medicine, but there's a part we neglect also. It's a weight maintenance methods also. So in this lecture I add few tips of the weight maintenance also. And obesity is actually epidemic in this country. Our initial data come in the 1990s from the Devaka Fernando, and it was very, very low. It was not a problem at all. The prevalence was less than probably 8%. And then 2005, we collected some data, and it was relatively high. And you can see later, after 2-3 decades, the prevalence has increased 3-4 times. This kind of actually trend we don't see in even developed countries. So obesity has become real epidemic in this country, and not among our patients, even our health staff and almost all community, this is a big issue. As you've seen the previous lectures, so obesity associated with any other medical complication also like diabetes, metabolic problems, and snoring. There are so many metabolic problems also, in addition to psychological size. So this is actually one of the major health epidemic in the country, so we can't neglect that. In addition, unfortunately, in very low BMI, we have a risk. And compared to white Caucasians or Negroids, and South Asian have a higher risk for the obesity associated medical complications. And these studies we did probably 15 years before, and we identified those who are over BMI of 21, it's very, very low level, have a higher risk for the metabolic parameters. And some of our recent study shows when we measure body composition in a very low BMI level, we have very high fat percentages. For example, at a BMI 23, for the men, we have a 25% of fat, and women we have a 35% of fat, which is considered a real obesity cutoff. So, and in Sri Lankan community, probably we have to use a very, very low BMI to identify obesity, although we are using a 25 at the moment, and I don't think 30 is a good cutoff at all for the assessed obesity. So these are few of Sri Lankan studies. But most of our patients, they don't want to change their behavior, or they don't want to diet, or they really expect some magical pill. Unfortunately, at the moment, we don't have any curative or preventive drugs for the obesity. There are few drugs in the market. In Sri Lanka, probably have Olistat, which is a lipase inhibitor, and probably you can do a metformin. But other drugs are very, very expensive. There are GLP analogs, injections, and some oral drugs also, which are extremely expensive, and it's not freely available also. It is not optional for the most of patients. When we done a survey in Sri Lanka, but still there are a lot of over-the-counter obesity treatment products. In this study we did few years before COVID, we noticed there are over 100 weight loss products in Sri Lanka at that point. And none of them are evidence-based, but still these are like a multi-million business. Many people are taking this probably green tea extract, sometimes coffee extract, and many other things, Garcinia. They are widely available, but there are no strong evidence for these things for the weight loss. So this is like a Sri Lanka situation. So I'll move for the obesity. It's very, very complex scenario. You can see it associates many psychological, sociological, and activity level, and diet, and biological, and probably food pattern. So it's not very easy to handle. That's why we need a multidisciplinary committee. And there are some few medical reasons also, but I'm talking about what we see as an epidemic. That epidemic is not due to medical reasons, it's mainly due to these environmental factors. And you saw in the previous lecture also, although there are genetic components, the environment has a very important fact, and especially for this obesity epidemic. However, now this is very difficult thing, so we can't take all these complication method for our patients. So we should go for the very simple strategy, which we all know, obesity due to excess energy balance. So keep that kind of simple concept in mind. This is not like a perfect explanation, but this is enough for the most of your obesity management. In simple as that, if someone's got more energy than energy expenditure, that should store in their body. So simple as that. Probably there will be variation. As you saw in the previous lecture, first lecture, some might not respond for the low-calorie diet or even bariatric surgery like another person. It's always happening. If you take education, same. If there's a one good lecture, probably some students get a good marks, some students get a less marks. So always there's a biological variations. But everyone can lose weight to some extent with the different strategies if they follow this basic principle. If the energy intake is less than energy expenditure. So what are the approaches for that? Ideally, it should be low energy intake than expenditure. So it should be energy deficit diet. There are a few other things also. Meal replacement you can be used, and there are ketogenic diet, intermittent fasting. These are a common hot topic in this country also. There are many other weight loss strategies. So these are few things I'm going to discuss in today's lecture. Ideally, in the weight loss diet should be very personalized, and it should be low in calorie. But in this country, we have a huge problem. Although we know the calories come from these different micronutrients, but we don't know cooked food composition database at the moment. We have for the raw item, but cooked item we don't have. Even we have food cooked items, but it's really very difficult because we have a diverse amount of food plates or like food dishes, and it's vary from even one household to another household. Now, if you take a very simple dish like this coconut sambole, we don't know the calorie content. You can calculate using a Excel sheet, but it's not perfect. Where some people might add a little bit of onion or tomato. Another family might, they probably temper it. Probably it become dehydrated. So calorie content even will be different in the same dish. So we can't go for the real low calorie diet because we can't measure the calorie intake. And there's another limitation also. We don't have a strong data about our LNG expenditure also. And those who have done the study here, but Sri Lankan studies, probably have noticed our people are not eating a lot also. The always calorie consumption come like a less than 2,000 if you take as a mean. But they're still obese. Probably we have some problem with energy expenditure also. We don't have a data for that. Probably we don't have good muscle mass, and probably we don't have a higher metabolism like a Caucasians or black people, so we don't know energy expenditure also. Because of these things, we can't directly use this real energy calculation equations. So because of this problem, we thought about having like a plate concept, which is this 1/4, this red quarter probably for the meat item, and yellow quarter probably like a cereal item, and other half for the vegetables, and that half vegetable also probably dark green for the green leaf vegetables, and green for the green vegetable, and red for another vegetable. So that was our concept, and we calculated calorie using Excel sheet, not like a chemically. Then we found this is a relatively less calorie compared to usual our rice plate, which is like a 500, 600 calories. Probably this kind of plate contain probably 300, 350 calories. So this was one of the award-winning concepts. So we did a clinical trial on this concept. So what we did, and we identified 120 overweight people, and we gave a rice plate for the one group, another group, we asked them to eat like a usual manner. Both groups, we gave a basic nutrition advices. What we identify at the end, those who have followed the plate concept, they lost their body weight, of course BMI also, to some extent, not a magical effect, that's only 2.1 kilogram difference, but that was some effect, because this is just a one change. When you are going for the dietary changes, you have changed many factors. For example, if they're having a lot of sugar, you have to cut down that. If there's a full cream milk, probably have to cut down to non-fat milk, and they are using oil, probably have to cut down that. And this is only for the rice plate change, but we found some positive effect. And this is we widely explain, widely demonstrate like this. And in our plate, half should be vegetables, and quarter should be protein, and quarter should be rice. But it's beyond that. Now, if you take Sri Lankan curry, especially vegetable curry, they are very spicy and hot, And why is that? In the past, we were like a farmers. We eat like a lurumiris and milk rice. Why we have lurumiris for the milk rice? Because milk rice is not very tasty. You need to have something spicy to eat that. So same thing we apply for our rice dishes also. We eat a lot of rice with some spicy curries. So if you make this curries very spicy, you need more starch to eat, more rice to eat. So in the cooking practice, you have to give little more advice than that. You have to ask them to cut down the spices, and especially chili. And our green leaf vegetables contain sometimes coconut, which is also high in calorie. So if they really want to have coconut, they can take a coconut scrape and add water, squeeze and add the remaining part, or so which is not very high in oil. And when they are making fish or chicken also, it shouldn't be fried. But if it is a mirisata or kirata, there won't be an issue, because if you take pieces, there won't be any fat attached to that. This is about cooking practice. Actually, eating practice is a little more than that. They should start eating from this vegetable end. When they start eating vegetable, probably they feel fed up, then they can mix it with rice and eat it. But if they start eating from the rice end, probably they always feel they have more leftover vegetable, they try to serve more rice. So this is a concept we use for our patients, and there's a clinical trial also which shows there are modest weight loss with this concept. And a recent study done about shift workers working in the now local hospital, they have a relatively bad health habits. Is normal because they have a night shift, probably they get opportunity of eating more food, and probably they eat late. So what we did actually, we give a meal replacement, which is also locally produced meal replacement. We give to those people for their dinner. So they are not taking their food dinner when they came for the night shift. They are only taking that meal replacement. Full paper is not published yet. This is only protocol paper, but I can share our data. What we did, we identified like 80 obese night shift workers. When we divide for the two groups, then for the 8 weeks, one group we give meal replacement, it's just a shake. They are not taking their dinner, they are taking only that drink. And other people, they are eating like a normal food. What we noticed after 8 weeks, those who followed this intervention group and meal replacement method, they lost nearly 3 kilograms in the 8 weeks. And of course, they lost a BMI, and waist circumference also quite significant. They lost from the nearly 5 centimeters, and the waist hip ratio also. So this is another strategy, and this is another evidence-based method for the Sri Lankan context. If they have night shift workers, yes, we can give a meal replacement. So those are the, to my knowledge, these are the only interventions we have done in Sri Lanka about obesity management using our dietary patterns. Now I'll move for the other evidence, and I think most of you are practicing, you have at least heard about this ketogenic diet. What is a theory behind that? Because you are not eating carbohydrates, so you are using a ketone body as a primary energy source. And they lose weight, and there are no argument. How it's happened? In the first, when you cut down your carbohydrate, you lose your glycogen stores for the liver and muscles. So there will be some dehydration. Every glycogen molecule contains some water, so they lose some water. And later on, when you might think this eating chicken or omelette is very tasty, no, if you eat for only those food without carbohydrate for the longer period, it reduces satiety. So we will not eat a lot. So what we have noticed, people who are eating this ketogenic diet, they eat less. Also, ketone body have actually some effect for the satiety. So all these reasons, they lose body weight. However, there are a lot of downside, and most of the ketogenic diet have a high saturated fat. So it might increase the cardiovascular disease, especially those who have high cholesterol. And it's not cheap. Carbohydrates are cheaper, cereal is the cheapest in the country. So it's not cheap, and it's not very practical. Because most of our celebrations, our common dishes are carbohydrate based. So they lose their probably happiness also, and they can't follow for the longer period. And it's not possible in our culture. So because of this downside, we don't encourage ketogenic diet for the most of patients. There will be some patients, it may be relevant, but not for the others. Another common, I would say these are like a fat diet and intermittent fasting. It's simply you are not eating for the longer period, you are fasting for the longer period, you are eating only for the shorter period. There are several methods. Some other countries, they probably skip whole day, they don't drink, they don't eat much, they only drink very low calorie beverages, and they're actually not eating enough, getting enough calories for those fasting days. And common thing in Sri Lanka is a 16-8, so they eat only 2 meals probably, only 8-hour period, probably 16 hours they are not eating. Physiology is very simple, because now if you are eating 3 main meals, you get a 2,000 calories, probably if you are eating 2 meals, you don't get that amount of calories, you get a probably 500 calorie deficit. So ultimately, they lose weight because they are eating less calories. But there are again downside, because food provide not only calories, food provide nutrients also. If they take 2 meals, they do not get a 1/3 of nutrient for their body also. So they might end up with nutrient deficiencies, and those are very common in this country. Another thing is that when you're fasting for the longer period, how we can get a glucose for the breakdown of the amino acids, which is coming from the muscles. So these patients might lose their muscle mass also. And the long term, which is not practical, because we get a pleasure from the food, so they can't enjoy their normal routine. So those are not practical. So that's why we don't encourage this intermittent fasting method as a culturally helpful method for the weight management. I'll move for the other part. I think you saw in the previous year, those big losers also gained 40 plus kilograms within 6 years. So most of these weight loss strategies actually fail after 5 years. And you can see everyone has regained weight. And so there are very few evidence for the weight maintenance strategy. I think probably you all can help someone to lose weight, and probably you also has lost weight in your life, but it will be very, very challenging for the maintenance. So these are few dietary tips, and this elegant study comes in Symposium. This is the best medical journal in the world. And what they have done, after weight loss, after 8 weeks of weight loss, they divide this group for the 5 different small groups. One group can contain high protein, low GI food. Other group high protein, high GI food. Other one is a low protein, high GI. Other one high protein, low protein, low GI food. And there was a placebo group also. What they noticed, what you can see this red one, only those who had high protein and low GI food could maintain weight loss even after 24 weeks. So that's a kind of take-home message. So once they lost weight loss, probably they have to maintain high protein diet, not very high, it's like 25% of calories for the protein, probably low GI. That low GI means they have a unrefined cereal, probably more fruits and vegetables to cut down their GI value. So probably they will be able to maintain. So this is one of the very strong evidence coming for the weight maintenance. Another weight maintenance trial shows, if you go for this part, this is for the maintenance part, when you're adding more fruits and vegetables for their servings, so their daily intake, it will help them to maintain the body weight. As well as if adding more milk or dairy, that's also help them to maintain the body weight. And those are the only 2 they identify. There are no other significant difference with the food patterns. So probably your patients, if they really want to maintain, probably you should still encourage having more fruits and vegetables and dairy in that dietary pattern. And another evidence shows those who are getting like a frequent visit, even after weight loss, that's help to maintain. That's partly because of the behavior change also, because probably you are not changing diet very much, but you talk to them, probably you handle this difficult situation. So if your patient, once they lost weight, don't leave them. So give like a continuous support, probably 3 monthly, probably 6 monthly, then that will help them to maintain the weight loss. One of my final slide about the physical activity. We all know physical activity is very good, and it's good probably for the health and probably even for the weight loss. But actually, it's very interesting, those who are doing very heavy exercise only could maintain the weight loss. You can see those are the other group. Once they lost weight, it was average weight 90. After 19 months, they regained everything. They were active people also, not very active, but these people were highly active. Probably they do 1.5 hour workout for every day. So if someone wants to really maintain the weight loss, those public health messages, like 30 minutes per day, probably 5 days per week, may not be enough. They have to be very, very active. So in summary, obesity definitely public health problem, and there are some dietary strategies we can use for the weight loss in this country, and fat diet are not recommended. How to maintain the weight? Having high protein diet after weight loss also, and low GI food, and more fruits and dairy, and frequent visits with the healthcare workers, and probably high activity level. It's not like a normal activity level. And thank you for your attention. That's when you are practicing obesity, you have to be a role model also. So that's also I always insist. Yes, you have to be very active, and you have to maintain a BMI also. Thank you for your attention.
Thank you very much, Ranil, for your very practical approach in your lecture. And as we are now behind the schedule, I can allow 1 or 2 questions if there are. Any questions from the audience? If not, I want to clarify one thing. Now in some guidelines they say adhering to very heavy exercise is not lasting long, and not adherence is a problem. In that case, what is the place or needs non-exercise diet in it?
Really, the big changes are very difficult to maintain. So whether it's a dietary or whether it's exercise, if they change a lot, it will be very hard. So what this evidence shows, and those, for the health purpose, what we encourage probably 150 minutes per week kind of exercise is not enough for the weight maintenance. And if they really want to maintain, they have to do a harder way. For that, they need support actually. Probably they need some gym instructors, or probably they need to have some friends who are doing exercise, so they need a lot of social support and individual support for that. But it will be hard. In this study also there are over 100, but only 13% people consider as like a very active people. So it's a difficult thing always.
I have a question to Professor Muthupala. My question is, I mean, it's very interesting to about your presentation about CBT, because I am also, I firmly believe that it's very difficult when we are thinking about dietary modification and the exercise and all. Very difficult weight management. Most difficult thing is that, as Professor Anil explained, that most of the people, they return back to original states within very short period of time. So I was looking for this one, and I saw that leptin and the renin action can be changed by CBT. So what's your opinion on that? And because those hormonal changes can influence, because that we know that especially ghrelin and the leptin can have a huge impact on change in the dietary behavior. So what do you think about that?
Yeah, as I explained, whatever the underlying mechanisms, the cognitive behavior therapy is very simple. At the end of the day, I mean, it's the relative contribution of genes, environment, whatever it is. But if you have an issue with your dietary intake, then you can change that by changing the behavior related to dietary intake by using cognitive behavior therapy. So it's very difficult to sort of give in 1 or 2 minutes. But the basic thing is everything what we do in life, because in our heads we have like schemata. It's like arranging your books in a cupboard. We arrange the old books, new books, history books, subject books. So in our head, the way we think, there is a thing called schemata. So that's based on our assumptions, core beliefs, the way we think. So by changing that, to give you an example, say like if I'm after a very full meal, if a man comes asking for food, I will always feel guilty, if he came before, I would have given, because I have been trained in the way, then I will look to give something for him. That's my behavior. But if somebody else not having that belief, say, so that's, we process our information through that schema. So whatever the information comes from the 5 senses regarding food, you can change what is in there by changing the way you think, which has an influence on the feeling and behavior. Or the other way around, you can change your behavior, like Lord Buddha did, to change the way you think or how you feel. So it's a very easy thing to do if you master it. But you can use the basic fundamental generic principles. What you have to do is first to get a very good assessment from the person, what that person's belief about self, others, about food, behaviors. Then once you do that analysis, you can try and address each and individual thing. It's a generic answer as well, but there are basic skills you need, techniques you need to use, like any other thing, like giving an injection, measuring the blood pressure. So if you master that, you can use that for anything, practically anything, not only diet, controlling your own emotions, anger. Thank you. Hope that answered the question.
Thank you all of you for your impressive lectures. My question is straightforward to you, dear Dr. Ranil Jayawardena sir. as you mentioned, the obesity and the weight reduction thing, if some, as practicing, we know that in the weight reduction program, first few months or first few weeks, the weight is smoothly going down. But there's a place when it comes to a plateau. In such case, what is your recommendation as an expertise in this field? And in that point of view, are you recommending some intermittent fasting or some fasting thing? Thank you.
That's a good question, actually. That's a good question because this is also very similar like economical exam. Now we got now we have an income tax problem. Then what I have done today, I spoke to a few colleagues also. They said they have cut down the expenses. Body does the same thing also. When you go for the low calorie diet, and body thinks like it's bad for the survival. So body same time they cut down the metabolic rate or metabolism. And so after probably 10%, we reach for this plateau phase. So you are getting a low calorie diet, but your body expenditure also same. So we call this a hit to the plat. When this plateau come, that will not work very much. Then that situations to increase your weight maintenance method, for the maintain your body weight, it should be like exercise and the cognitive behavior therapy or behavior therapy. So it should be the exercise the only way because it increase the muscle mass and probably it will help to lose the fat also. But there won't be body weight change, but there will be a change in the body composition. And that's why we have got the right targets. People who lose a lot, like a 20% body weight, 30% body weight with a diet, it's almost impossible to maintain. But if it's a 5 to 10%, which is very easy to maintain with the day-to-day exercise also. So exercise should be the method to maintain the weight. And we don't encourage intermittent fasting or anything because one thing, as I mentioned, it have a negative effect for the health because it cut down the nutrient intake and probably they are not enjoying their food. And actually with the intermittent fasting, their metabolic rate drops. So when they eat another large meal, next day they gain the weight also. So we don't encourage that. But pharmacologically, you can go orlistat also for the weight maintenance, which have some effect for when they have a really heavy fatty meal, probably it have effect for the cut down the fat absorption.
That is the end of a very fruitful session. I am very thankful to all the speakers on behalf of the Nutrition Society of Sri Lanka.
Before we conclude the Symposium 3, let us take this moment to appreciate the speakers. For this, I would like to invite Symposium Chair, Professor Chandima Vikramatilaka, Department of Biochemistry, Faculty of Medicine, University of Ruhuna, to give away the tokens of appreciation to the speakers. Professor Atula Sumatipala, Professor Anil Jayawardena, I would kindly request Professor Chandima Vikramatilaka to remain on stage. Now I would like to request Dr. Dhammika Senanayaka, the President of the Nutrition Society of Sri Lanka, to be on stage to give away the token of appreciation to Professor Chandima Vikramatilaka, the Chair of Symposium 3. Thank you. Now we are moving forward with the free paper session. Let me invite Dr. Kumari Ratnayaka, former head of the Department of Applied Nutrition, Vaimbu University of Sri Lanka, to chair the session. Over to you, madam.
Once again, good afternoon everyone. We are going to start the free paper sessions. So this is one of the important sessions in this today's event. So actually the young or the budding scientists are present there, the research work or showcase their research work. So this is very important for our young scientists. So today we have got 7 presentations. So before starting the sessions, I would like to introduce our judging panel, Professor Anand Chansekara, attached to the Department of Applied Nutrition, YMP University of Sri Lanka, and Dr. Shashi Veerasinghe, attached to the Department of Sports Science, University of Sri Jayawardhanapura. So we will be evaluating our presenters. So in the tomorrow's sessions, we are going to give away the Best Presenter Award based on their presentations. So we have selected 7 presentations today. The first presentation is based on fruit and vegetable stories, digital storytelling to influence dietary behaviors of young children. The authors are A.A.H.N. Gunasena and T. Pereira. The presenting author is A.A.H.N. Gunasena. So before starting the presentations, so I would like to briefly tell the time limit. So you will be given 8 minutes followed by 2 minutes. So you can see the time in front of your display. So please be adhere to the time as we are running behind the time. So at the 7 minutes of the presentations, so I would suggest you to conclude your presentation, so then we can save our time. Thank you.
Good afternoon, ladies and gentlemen. I am Hashini Gunasena, today presenting my research on digital storytelling to influence dietary behaviors of young children. Although fruits and vegetables are nutritious, dense, cheaper source to address most of the nutritional issues among children in Sri Lanka, their preference to eat these fruits and vegetables are not much high. So, I use the powerful potential in storytelling combined with the digital technology as a solution. So, my journey begins with the aims to assess current fruit and vegetable consumption patterns among primary school aged children in Sri Lanka, and thereby to develop a novel digital tool which is mainly based on digital illustrations for storytelling, and finally to evaluate the use acceptability of the developed digital tool. So, this is how I created the digital tool and evaluated it. First, I carried out a qualitative survey to gather preliminary data. There, I conducted 27 focus group discussions in 9 schools in Uva province while meeting parents, teachers, and students. By using emerged themes from these focus group discussions, I created the storyline of the digital storybook. So, the created storyline was evaluated by an expert panel. My expert panel consisted with dietitians, an educational expert, a child psychologist, and a child nutrition scholar. The developed digital tool was distributed among the sample to be used within 1 week. So, the developed digital tool was evaluated by using a pre and post quantitative survey. So, this is a quick overview of the digital storybook I created. these are the key findings of my research. From the focus group discussions, I found out that teachers and parents did not satisfied about the current fruit and vegetable consumption patterns of their children. Teachers revealed that the green leafy vegetable consumption is much lower and there are no any fruits incorporated with the lunch packet of the children. And parents confirmed that most of their children do not prefer to eat several varieties of locally available vegetables. So, in order to develop a successful digital tool, I gathered some data from students about their preferences about these fruits and vegetables. At the same time, I collected some data about some factors such as the characters to be appear in the developing digital storybook. There, most of the children preferred fairy characters, animal characters, and the children characters. After using the digital storybook for a 1 week of period time, I was able to find out that there was a statistical enhancement in the average fruit and vegetable servings per day of the children. So, it can be concluded that an interactive digital storytelling can influence the fruit and vegetable consumption patterns among the primary school age children, and at the same time, parents, teachers and students accepted this digital tool as a useful digital tool for nutrition education purpose. So, finally, I would like to suggest, rather than always refracting our youngsters from using these digital devices in this digitalized century, we can use this type of innovative strategies to enhance their nutritional conditions. Thank you.
Thank you very much for your very nice presentations, and the presentation is now open for the discussion. Any questions from the audience? Yes.
Can I know what is the software that you use?
Actually,
Very nice one.
thank you so much.
Although it's very short, very useful.
Actually, madam, it's a quick overview. The storybook is about 6 minutes. At the same time, I incorporated the digital game along with the storybook. It is not shown here. There are several softwares I used. I created the digital illustrations from a software called iArtbook. I drew the arts, and after created digital illustrations, I edited it using a CapCut software.
Yes.
Question. Okay. So I appreciate the work. Now, one of the findings or the conclusion is that your digital storybook increased the consumption of fruits and vegetables of the study group. Am I correct? Yeah.
Yes,
sir. If I say that when you distributed these books among the children, parents got motivated and the parents offered more fruits and vegetables to the children, and that is the reason, but not the storybook motivated the children. What is your idea?
Sir, I distributed a quantitative questionnaire to evaluate this. So the pre and post questionnaires were given.
To whom? To whom?
Yeah.
Questionnaires were given to parents?
Yeah, parents, and that from grade 1 to 5 children were incorporated in my study. So actually it is a limit. It can be a limitation, as Sir said, but when I got the parents' opinion from themselves, they talked with me and told that the children are asking from parents after using the digital storybook. So
I understand that. So the children accepted.
Yeah.
So that's why they are really consumed. But probably there can be an influence on the parent side as well.
Yeah.
And the prepare them and give, otherwise the children cannot decide, or children cannot eat by deciding themselves that this is what I should eat. Okay.
There are some parents told that bitter gourd-like vegetables are not usually taken by children also, but after using this, there was some.
We accept those things. Okay, thank you.
So did you assess their knowledge before and after the intervention? So,
yes, madam.
So how did you assess?
Through a quantitative survey.
Okay, so you observed improvement, significant improvement.
The statistical improvement was shown through the survey.
Okay, thank you so much for your nice presentations.
Thank you. Thank you.
The next presentation is malnutrition among preschool children in Medical Office of Health Area, Samanture. The presenter is M.H.M. Azad.
Good afternoon, the chairperson and the panel of judges and their colleagues. Today I am presenting part of my study, malnutrition in medical officers area in Samanture. Samanture is situated in Ampara district, coastal towards Kalmane, 20 kilometers from Ampara town. So as you all know about the malnutrition burden in the country under 5 years age is significant public health issue, and when it comes to malnutrition itself, this is underweight, wasting and stunting is, as claimed by the media, it's a public health issue. But when it comes to the rural area where this study was conducted, actually as a hospital director I would like to wanted to know about the real baseline statistics in the community. That's why this study was carried out, and especially it is become a critical concern during this economic downturn in the country. So when it comes to the malnutrition and increasing number, definitely it will aggravate the inequalities between the districts. District disparities already is existing due to the social determinants of health. So when it comes to nutrition or malnutrition, it is not only one factor, there are several factors affecting this condition. So there is a vacuum of study in malnutrition in our part of the region, and this study was aimed to assess the nutritional status of preschool children in the MOH area, Samanture. And Samanture MOH is about 80,000 population, and there are about 24 public midwives areas, and it was divided as it is here. And out of that, now in the preschools where I conducted the studies, 81 schools were registered with the DS office, and there are about 200 schools are functioning, but the study setting I selected only the registered schools, very convenient sample, so I selected only 10 schools. Out of the 10 schools, 350 children were included in the study. So the study period was only 1 month. So as I said, I selected only 10 schools out of 81 preschools, and anthropometric measurements were measured, and actually this was used as a health file for each and every children in the study schools. We open a health file where it is kept there for the continuous monitoring and future referrals from the MOH for the clinics. And actually we included only the 4-year and 5-year-old children, and the software I used from the WHO Anthropos software, and Excel sheet. And ethical and administrative clear was obtained. So the study actually these two parts. One is now what I am presenting. Another study is currently I am conducting about the associated factors like parental income and knowledge, educational level, and the number of siblings, and the area, whether they are purchasing power and other factors I am studying. This is straightforward. The measurements of the height, weight, and the age. So average age was 4.8 years. The average height was 101, and weight was 14.6. Out of total samples, majority were boys. The percentage of moderately and severely wasted were as 16.68 and 3.9. Not as claimed in the media as very high. And while the percentage moderately and severely stunted were 5.7 and 2.3 respectively. The percentage of moderate underweight was a bit high, 35%, whereas 2.6 were overweight and 0.28 were obese. These were the study findings. So the conclusion, the studies revealed wasting, stunting, and underweight were a little higher than the study found in urban settings and other studies, and the obesity in this study sample remained low. The emergency nutrition plan, including involving the stakeholders, community sensitization, advocacy on appropriate nutrition for preschool children, should be implemented. And we have already, after the study, started a SAM clinic, severely acute malnutrition clinics already started with the help of the regional directors, and we are giving the BP 100 biscuits for this identified children, and also the mothers are given for the transport allowance with the help of the local NGOs. And regular monitoring, as already it's happening, regular monitoring of growth preschool children are crucial in the clinical management, and the policy decision and each district area specific strategies should be integrated in the life cycle approach. And further studies are already have been undertaken to identify association with socio-economic factors on child malnutrition and micronutrient deficiency are recommended. These are the references I went through. Thank you very much.
So thank you very much for your presentation. Now presentation is open for the discussion. Any questions from the audience? Yes, please. Yes, Mrs. Saka.
Thank you very much for that. My question to you is, now this age group is usually studied through regular growth monitoring as well as nutrition month data, right? So there is nutrition month data. Now I understand that you are doing further studies on associated factors, but when you consider this study, what was your real objective of doing it? Because anyway it's in the regular growth monitoring sphere, but it may not be 100%, of course. The denominator of regular growth monitoring is not 100% for sure. So that's my first question. What was the real objective when this data exists at some level? Number two, did you compare this age group with the regular growth monitoring data and the nutrition month data? Right? Third question is, do you find some sort of anomaly in the measurements done in the regular growth monitoring versus this kind of, specialized assessment? Thank you.
Okay. The first answer is, now although the regular monitoring is done, the growth monitoring done, as you said, it's not done properly. And especially the preschool children, 4 to 5, it's not, the statistics are available. I really wanted to know the baseline level to find out. That's why I did it. because it's MOH areas and the regular midwives, it's doing it. But as you all know, I'm afraid that it's not 100%. So that is the one of aspect. And also I would like to study the associated factors mainly. So this part is the first part I presented here, but I already am doing the other study to find out. That is the main objective of the study, to find out the real thing. The comparative aspect, the data with the available with the FHB and the regional one, it's regional one is, my study is not that much very high, but the claim is. Now when it comes to Family Health Bureau is underweight, is now is 14.8 underweight is for the national figure, and also standing is 10.3 or something, but the wasting is 10.1. So even obesity is 0.5 odd. So my study is there is a difference. So the regular monitoring is there. My aim was to find out really it is done or not, but I am afraid it's not.
So I hope you are willing to advocate with the Family Health Bureau.
Yeah.
Yes.
Yes.
Is very important.
That's right.
But I must say that the Family Health Bureau never denies that there could be some, errors and so on.
Yeah.
So it's very, very important that the minute details are discussed.
Yes.
As part of the MCN subcommittee.
Thank you.
What may be the reasons for the lower prevalence of stunting in this particular area?
Yeah, actually, this area is mainly farmer community, and the parents and the schools are not, in terms with the good. There is no relationship at all. The children goes to school, parents they are separated. The parents and the school communities are not lined with to take any decisions. Also, they, for the sake of sending school, they send, and they don't know what's happening in the school itself. So my idea is to open a health file for them, and I had already a discussion. I went there, sat with the MOH and discussed, and the school children also. And the DS office, I met DS with the early childhood development officer. Now I've been appointed to look into these matters. And also the stunting part, I don't know, really my study was done in the selected convenient sample. So I would like to, include all the schools, even the unregistered schools, and to find out the larger number, sample size, then would have been a different. No, I can't generalize these findings.
How do you compare it with the nutrition month data and the regular growth monitoring data? I think that is the question. Or maybe in the future you should then compare.
Yeah.
To see.
That's right.
Because it's very low.
It's becoming a national sensitive issue when it comes to nutrition data itself. So, so this is going to be an issue then again. So I'm afraid in that aspect as well.
I think you have to make issues to make the system right. So I hope you continue.
Thank you.
Okay, thank you very much for your presentations.
Thank you.
And the next presentation is on use of sun exposure determinants to develop sun exposure questionnaire to estimate vitamin D status in young adults. The authors are RMTK Ranatunga, MNA Shireen, B. Abija, and AMNT Adhikari. The presenting author is MNA Shireen. Over to you.
Good afternoon, everyone. The sun is the powerhouse of the world, the ultimate source of all the other energy that living things need to survive. Of course, sunlight is a blessing. In that way, our study was focusing on the relationship between sun exposure and vitamin D status under the topic of use of sun exposure questionnaire to estimate vitamin D status of young adults. Like all other vitamins, Vitamin D is one of the most important vitamins for many other bodily functions. It can be obtained through dietary sources. It is a unique vitamin because it is the only vitamin which can be synthesized by skin through sunlight exposure. Vitamin D is very essential for musculoskeletal health. But today, vitamin D deficiency is a major health problem worldwide now. Although there are several other ways to assess vitamin D status, the biochemical assessment of serum 25-hydroxyvitamin D concentration is the gold standard method, which is quite expensive and still impossible for poor community. On the other hand, quantifying sun exposure is a proxy indicator of vitamin D status, but still, no studies have been to develop a sun exposure questionnaire in Sri Lanka. So, our aim was to develop a sun exposure questionnaire to estimate vitamin D status of young adults in Sri Lanka. And our objectives were assess the vitamin D status of young adults in selected rural areas in Sri Lanka and identify the determinants of vitamin D status of young adults. We choose to conduct this study as a cross-sectional study design in Pannala Divisional Secretariat, mainly in Medirivilla, Elabadagama and Ihalamakandura Grama Niladhari divisions. By recruiting around 75 young male and female participants, those who are at the age between 18 to 45 years old, through stratified random sampling. And our stratas were gender, ethnicity, and age group. For the data collection purposes, we have used some specific types of tools like a general questionnaire, which includes most of the socio-demographic factors. Also, we developed a sun exposure questionnaire including most of the sun exposure behavioral factors like sun exposure duration, nature of occupation, sun exposure body area. Here we have used rule of 9 theory. Also skin color. It was determined by Fitzpatrick scale. Moreover, use of sunscreen, sun avoidance behavior and clothing habits. In addition to this, we have used International Physical Activity Questionnaire, which is shortly named as IPAC questionnaire, to assess physical activity level of the individuals. Moreover, we have collected anthropometric data like weight, height, waist to hip ratio, skin fold thickness from the recruited participants, followed by 20 milliliter of blood samples were collected for the serum 25-hydroxyvitamin D concentration test, the ELISA test, the biochemical assessment. Once we're done with the data collection, we stepped forward to the data analysis. During the data analysis process, the serum 25-hydroxyvitamin D concentration was classified based on Institute of Medicine cutoff value. Also, we developed a sun exposure scoring system and we calculated sun exposure score for each and every participant based on their sun exposure behavior. Now, the most important part of this presentation, the outcome of our research, what made us stand in front of you. The major findings of our studies are mean serum 25-hydroxyvitamin D concentration was 49.7 nanomole per liter. Also, through this distribution, we could identify that more than half of the participants were in insufficient and deficient vitamin D status. When we focus on the socio-demographic factors, the factors like gender and the age group were significantly associated with serum 25-hydroxyvitamin D concentration. Specifically, the male participants shows higher serum vitamin D concentration compared to the female participants. Also, those who are at the age above 37 years old shows higher serum vitamin D concentration due to their habitual sun exposure behavior and their nature of occupation. Meanwhile, there were some factors we could observe that no association with serum 25-hydroxyvitamin D concentration, and they were income, ethnicity, waist to hip ratio, and skin fold thickness. When we focus on sun exposure behavior of the individuals, we could observe that the nature of occupation, sun exposure duration, and skin exposure body parts were significantly associated with serum vitamin D concentration. If we deeply look into this, those who work in both type of work settings like indoor and outdoor shows higher serum vitamin D concentration. Also, the people those who exposed to more than 30 minutes of sun exposure shows higher serum vitamin D concentration. Also, based on rule of 9 theory, the people those who expose 20 to 40% of their body parts shows higher serum vitamin D concentration. So through this, we can clearly say that these sun exposure behavioral factors mainly influence on vitamin D status of young adults. And this is the questionnaire, sun exposure questionnaire we developed, and the highlighted factors are the factors which is significantly associated with serum vitamin D concentration. And still, we are on the process of developing sun exposure scores to get more associating factors. As all the path has its own obstacle, we came across some barriers throughout our study, like our sample is not a representative sample for all the rural area young adults in Sri Lanka, because we have recruited the samples only from Pannala Divisional Secretariat. Also, our sample size is a comparatively lower. Moreover, low variations in socio-demographic informations. However, we believe that our study would be a doorstep for many other upcoming studies, like develop a sun exposure questionnaire using different scoring system, also validation of the sun exposure questionnaire with large number of sample size. Last but not least, if I conclude overall outcome of our study, I can say that more than half of the participants were in vitamin D insufficient and deficient status. Also, the sun exposure behavioral factors like nature of occupation, sun exposure duration, and skin exposure body parts can be used as a tool to estimate vitamin D status of young adults. Finally, I wrap up my presentation with heartfelt thanks for this opportunity. Thank you very much.
Thank you very much for your very informative presentation. Now presentation is open for the discussion. Any questions from the audience? Yes. So we can allow one question. Sanand.
Don't you think that, have you done their dietary behavior, have collected data for that?
Yes, sir, we have collected 24 recalls of the participants.
So any relationship between the dietary behavior and this vitamin D?
No, sir. No, sir. The people, those who consume the animal-based foods, they show higher vitamin D concentration. It is the finding the Muslim participants, they usually covers their whole body, but they show a substantial amount of vitamin D level. It is due to their animal dietary intake, so like fish, meat, chicken, which is rich in vitamin D.
Okay.
Okay, thank you very much for your presentation. The next presentation is the comparative study of 8 selected front of pack labeling systems in different countries and explore importance of the potential harmonization. The authors are HSK Nisansala, STC Mahavitanage, and DMUAJK Dasanayaka. The presenting author is HSK Nisansala. Over to you.
Good afternoon, all of you. The topic of our study was comparative study of 8 selected front-of-pack labeling systems in different countries and explore importance of the potential harmonization. So I will continue this presentation under these subtopics. First, I will give a brief introduction. So in the modern world, complex lifestyle of the people along with the advanced food manufacturing technologies has led to an accelerated nutrition transition to diets comprising significant proportion of processed and ultra-processed food and beverages. So they typically contain excess amount of salt, sugar and fat and are often highly caloric dense. So these products are greatly abundant in the modern food retail environment with sheer number of food choices, making it hard for consumers to make healthier food choices. Therefore, rapid consumption of these unhealthy products has become a major cause for risk of non-communicable diseases, indicating the necessity of nutrition-related policies. So as a result, this front-of-pack labeling has been introduced as a preventive strategy for these non-communicable diseases, and therefore many appropriate schemes have been introduced worldwide, which has become non-tariff barrier in the global food supply chain. So the objective of our study was to comparatively analyze the selected system, exploring the potential framework for global harmonization. So we selected 8 systems and gathered information from databases, international guidelines, and country-specific regulatory guidelines, amendments, and policies of the selected system. So in definition, front-of-pack labeling is a supplementary nutrition information which presents nutrition information on the front of the packaging as symbols, graphics, text, or a combination, providing overall nutrition value of the food. So the primary aim of these FOPL policies is to provide consumers with readily understood nutrition information on the healthiness of the product, enabling healthier food choices, with the secondary aim of stimulating producers' knowledge and attitudes to improve the product quality. Thereby, it can be indirectly beneficial for the government economy, saving the government healthcare costs by decreasing the burden of non-communicable diseases. So the 8 systems we selected were namely reference take label, traffic light label, multiple traffic light label, warning labels, Nutri-Score, Nutri-Inform battery, health star rating, and endorsement logos. So as we can see in these charts, these systems can be broadly categorized as interpretive and non-interpretive systems. So these non-interpretive systems merely repeat some or all the numerical information from the mandatory nutrition declaration without providing any conclusion of the healthiness of the product, and it requires more cognitive effort to understand. In comparison, interpretive systems use interpretive aids such as colors, shapes, and icons to provide an evaluation of the product, making it accessible for people with lower health literacy also. In addition, these systems can be categorized into another 2 parts as nutrient specific and summary indicators depending on the type of information they provide. These nutrient specific systems provide information on the content of a given nutrient, whereas summary indicators provide an overall idea of the healthiness of the product. So these variations of these systems are due to the country-specific aims and regulation along with their presentation, which lead to their strengths and limitations. For example, interpretive systems are more efficient than non-interpretive systems as they give a quick understanding. Also, color-coded systems are more efficient than monochrome as colors and shapes are more accessible for the human perception. So as I said earlier, due to the complex requirement of the people and advanced technology, global food supply chain has complex in the modern world, and food has become an important component of the global trade. So as a part of this international trade, food labels often cross borders, and as different countries use different labeling schemes with different labeling requirements, this has created technical barriers to the free movement of packaged foods, requiring the necessity of front-of-pack label harmonization. And this lack of harmonization has resulted in the need for food industry actors to adapt to different labeling requirements at different markets, even within the same trading region. So, although global front-of-pack label harmonization is much important and highly suggested, it is challengeable due to several reasons. Of them, different nutritional needs of the people is the major concern. Different populations, even within the same country, may have different dietary habits and cultural preferences. Therefore, nutritional requirements in one country may not be compatible with another. apart from that, although international guidelines and standards are available, some countries may still have their unique regulatory framework prioritizing different health concerns. Apart from that, different systems indicating different nutrients, serving sizes, references values, different nutritional parameters and profiles, difficulty in comparing products, and in some cases difficulty for applying into all food categories make this harmonization difficult. However, efforts can be still taken for the harmonization. In that case, international guidelines such as Codex, WTO agreements, mutual recognition of standards and requirements of different countries, and information sharing will be quite helpful. Most importantly, regional harmonization with similar dietary habits and requirements will be more feasible than global harmonization. And moreover, government involvement, research studies, public awareness, and continuous monitoring of the particular system are highly suggested for an efficiently working FOPL scheme. So in conclusion, front of pack labeling is considered as a non-communicable disease prevention strategy worldwide. Therefore, different FOPL systems has been implemented worldwide, which has become an non-tariff barrier, indicating the importance of harmonization. Although global harmonization is too difficult, efforts can still be taken. Regional harmonization will be important in that case. In addition, country-level follow-up programs are highly suggested for their intended outcome. So that's the end of my presentation. These are some of references used. Thank you.
Thank you very much for your informative presentation. Any questions? Yes, according to your view, so what is your general idea about the food labeling system that the front label packaging used in Sri Lanka? So do you think it is enough, or any views regarding that?
It is efficient to some extent because many people are aware about that and they choose products by looking at the labels. But when it comes to the majority of the general public, although they are satisfactory knowledge, it is not important as the price and expiry date yet. It may due to the current economic crisis we are facing. Therefore, there should be more awareness programs, and also media restrictions can be done. In addition, some tax applications can be done.
Okay, any questions further? Okay, thank you so much for the nice presentation. And the next presentation is on design of low-cost one-dish meal menus for canteens in public universities in Sri Lanka. The authors are GMS Sarap, KARN Kavindi, MSF Sirasa, IPM Vikramasinghe, and GAP Chandrasekhara. The presenting author is GMS Sarap. Over to you.
Good evening, everybody. I will start the presentation with a question. So this is a picture of meal which provided by State University. So the people who are more concerned about food and nutrition, do you think that we can fulfill our macro as well as the micronutrient requirement according to the recommended level by consuming this kind of foods? Actually, can we fulfill our nutrient requirements as well from the vegetables with this economic crisis? So as a food science and nutrition student, I thought to find a scientific solution for this problem. So designing of low-cost one-dish meal menus for canteens in public universities in Sri Lanka. So when we consider about the canteen meal, so as we all experience, it contains more rice, low vegetables, and low fiber as well as the low protein. When I find the scientific solution for this problem, I came a solution that is one dish meal. So let's look at what is one dish meal. So one dish meal is one of the most common concepts in the European countries, but when it comes to the Asian countries like Sri Lanka, we are not much familiar with the one dish meal. The meal which fulfill both macro and the micronutrient requirements, and low preparation time and more convenient food dishes are called as one dish meals. So when it comes to the my one dish meal concept, it consists two additional characteristics where when we consider about that special characteristics, they are high satiety response value as well as we can prepare it in affordable prices. So aims of this research is to design nutritious high satiety response one dish meals for affordable prices. After that, to introduce the one dish meals for university canteens. So I conducted this research into three main steps. So let's look at what is that. So as first step, I did a comprehensive market analysis to identify the commonly available vegetables in the market. Especially I consider the underutilized crops, vegetables which are rich in macro and the micronutrients. So as well as the most important part of the market survey is to find vegetables which we can get for low price. After that, the next question came to my mind is whether is there a gap between usual intake and the recommended value. So I collect the dietary recall data using 24-hour dietary recall from 50 participants. So you can observe the values like usual mean intake, mean values of these I collected from the 24-hour data recall. According to that, the percentage of energy comes from the fat and the protein is lower than the recommended level, and the percentage of energy comes from the carbohydrate is higher than the recommended value. So after getting the data from the market survey and the 24-hour data recall, I started to design meals. So when I design the meals, I focus about the nutrient to fulfill the nutrient requirements of the consumers. So I follow food-based dietary guidelines. So as we all know, when we consider about the plate methods, half a plate should consist of rice and 1/3 of the plate should consist of protein and 2/3 of the plate should consist of vegetables. Following these food-based dietary guidelines, I create 30 nutritionally balanced meals, and I did trials for those 30 nutritionally balanced meals. And the price range from 120 rupees to 150 rupees. This is the 30 delightful culinary creations I created from this research, such as wire pumpkin ash melange, wire pumpkin asia patch, and wire chickpea delight. As second step, I did a sensory evaluation as well as analyze the sensory response value of each meal. In the sensory evaluation, I did that using 50 participants to evaluate the 10 sensory attributes such as appearance, color, aroma, and taste, and overall meal experience using 7-point heteronomic scale. From the data we collected from the sensory evaluation, I selected the 3 top meals, best performing meals. The selected meals were used to calculate the satiety response values. So we determined the satiety response value using 15 participants who belongs to healthy BMI value. So as final step, I introduced these 3 best performing meals to 5 canteens in Wyoming University, as well as I collected the feedback from the canteen consumers as well as the canteen people using QR code using a Google form. So this slide shows the sensory data I collected in this research. From the sensory data, I select 3 best performing meals. They are wire chickpea delight, wire peanut crunch, and wire okra medley. So this slide shows the satiety response value of best performing 3 meals. So the orange color line indicates the satiety response values of each meal, and blue color line indicates the satiety response value of control meal. So we use canteen meal as control meal. So you can observe that the sensory response values are almost all the sensory response values of the developed meals are higher than the control meal. So when I compare the nutrient composition between canteen meal and the developed meals, I analyze the nutrient data using Foodbase 2000, and I came to know that percentage of energy comes from the macronutrient is in line with the recommendation levels. So now you are looking what is the speciality of this design meal. By consuming this one proportion of one dish meal, so you can fulfill your more than 50% of daily vegetable need. As well as when compared with the canteen meal, it is in line with the energy from the micronutrients. As well as we are always trying to use underutilized vegetables which are rich in vitamins and the minerals. As well as in each and every dish which consists at least one green leafy vegetables as well as the pulse or a nut group. So it's time to wrap up my presentation. So as I previously said, the most best performing 3 meals were via chickpea delight, via peanut crunch, and via okra mainly. And according to the satiety response values, as well as by looking at this nutrient composition value, so you can identify that these best 3 meals can fulfill the nutrient macro and the micronutrient requirement while relieving our hunger. As well as we can get it for the affordable price. So when I talk about the outcomes of this research, so I am currently developed recipe book in 3 languages with the collaborations of Ministry of Agriculture in Sri Lanka and promote healthy eating whole country. As a future direction, I would like to suggest if we can do laboratory analysis to analyze the nutrient composition, so we can get a clear, in-depth idea about the nutrition composition of the meals. So I would like to express my sincere gratitude to the people who helped me to make success this research. So eat healthy and live healthy. Thank you.
Thank you very much for your nice presentation. So we can allow one question from the audience. Any burning question? Yes, Mrs. Mala, go ahead.
When consider the nutrient composition in your meals, I noted that carbohydrate content is more than 100 per meal. Nutrient composition slide.
Nutrient comparison.
Composition. Carbohydrates in grams. Yeah. So carbohydrates more than 100 per meal. So I think if you can reduce it, that is for a meal, I think it's too much.
Yeah. Thank you for the comment, madam. According to the, we have to do this according to the canteen policy. So, according to the canteen policy, there should be 490 grams of weight in the food packet or food plate. So, that's why I use this much of carbohydrate. So, we thought to get carbohydrate from the rice, and so I follow the food-based dietary guidelines.
This is about 1 meal, right?
Yeah.
You have to revisit. It's a very creative presentation, very good. Now we have been doing this for a long time. Lot of information to share. Let's talk about it, but your idea is very good.
Thank you, madam.
For your nice presentation. Now we are moving to the next presentation. It's on Sri Lankan parents' view on grades 6 to 11 food literacy education and school food environment for children's well-being. Authors are MPS Ratnayaka, J. Nanayakkara, T. Pereira, A. Wasley, A. Booth, and KDRR Silva. The presenting author is MPS Ratnayaka.
Good evening to you all. I'm Purnima Ratnayaka. As a part of our food literacy education research, we conducted focus group stakeholder assessment, stakeholder opinion assessment studies with the stakeholders in Sri Lankan education system, and one of the stakeholders were parents. We selected parents for our research because they have close relationships with the children, and also they have a better understanding about the school food literacy education and also the students' behaviors and practices as well. When we consider food literacy, it covers broad concepts of food, including food, nutrition and health, agriculture, food manufacturing, environmental, social, cultural, like broad aspects related to food. The aim of this research was to investigate the current state of secondary school food literacy education and school food environment in terms of skill development and practical applications. We conducted this as a qualitative study with the participation of 53 parents through 8 focus group discussions. We used maximum variation sampling technique here to identify the participants from 6 provinces in Sri Lanka. In the data analysis part, we used thematic analysis technique to analyze data with the help of NVivo 12 software. 5 themes were generated to analyze the data, and they were the importance of food literacy education, the current food-related behaviors of the students, parents' anticipations, barriers to food literacy education, and school food environment. We wanted to examine the parents' opinion about the importance of delivering food literacy education to school children and what they want their children to study through schools. And also we wanted to share their experiences about the food related tasks performed by the students at households, and also parents' experiences with their students' knowledge and skills. And also we wanted to examine the parents' opinions about barriers related to food literacy education in Sri Lanka, and also their thoughts about the school food environment as well. This is the demographic information of the parent sample. Out of 53 parents, there were 46 mothers and 7 fathers, and all of them were between 37 to 59 years old. As you can see, there were more parents who had educational qualifications up to A-level or O-level education levels, and also most of them were housewives. Then let's move to results now. And when talking about the importance of food literacy education, all parents agreed that it is important, and also they pointed that there is a high risk of developing health risks among young generation, and therefore it is important school food literacy education. And also they said that the children accept more what the teacher says than the parents say. And when we consider the expectations of parents, we identified that they want their children to know healthy food behaviors and also balanced diets. And also they wanted their children to learn behavioral modifications and good practices related to diet as well. When we consider the barriers as parents' perspective, they told that teachers are not sufficient to deliver the that means qualified teachers are not sufficient to deliver the food literacy education. And also they pointed out that teachers try only to cover the syllabuses and their focus towards skill development was less. And also when we examine the students' behaviors through the point of view of the parents, they had contradictory opinions regarding that. While some parents reported that the students, their children are more health concerned and they actively involved in food related activities at households, and the other parents told that some of the parents told that their children are not eating a healthy way, and also their involvement in food related activities are also less. And also about school food environment, the parents told that they are up to grade 5, there is a good program, good established program in schools, but after grade 5 it is less. And also unhealthy foods are sold in canteens as they reported. In conclusion, although most children have sufficient theoretical food related knowledge, their practical applications as well the involvement in food related activities are less. And there are barriers to food literacy education in Sri Lanka because there are lack of qualified and trained teachers, and also there are not sufficient resources as well in Sri Lanka, some schools in Sri Lanka. Parents suggested to add more food preparation lessons in curricula and implementing awareness programs in schools as well. They also suggested having more control over school canteens to prevent unhealthy food promotions. As recommendations, we can say that education authorities should implement practical oriented food literacy education programs and improve food environment in secondary school. Thank you.
Thank you very much for your nice presentation. I kindly expect silence in the rooms, because otherwise it will be disturbed for the presenter as well as for the listeners. So while enjoying your tea, please be silent. Yes. Now the presentation is open for the discussion. Any questions? Yes, sir.
Did you ask the parents whether the boys also should participate in food preparation?
Yes, sir. I asked what are their children's behavior and participation in food activities. I especially emphasized about their sons also. When they elaborating their ideas, they told that actually there is a huge difference between two genders, as they, according to them, sons' participation is less compared to daughters.
But do they like the sons to participate?
Yeah.
Right.
Since there are no more questions, so thank you very much for your nice presentation. So our last presentation for the today's sessions are the free communications. The next presentation is on pumpkin cucurbita maxima soup as a strategic weight loss meal replacement. The authors are BASRP Vijayaratna, DS Pereira, S. Mahendran, and KM Ratnayaka. The presenting author is DS Pereira. Over to you.
Good evening to all of you. Since we have been talking obesity and its related consequences and weight management strategies throughout the day, let me focus your attention on our research findings. Effect of pumpkin as a weight loss strategic food alternative for overweight and obese adults, an intervention clinical trial. As we all know, primary management of as dietitians, when we go for the dietary modifications, we always think for that patient's preferences and also economical feasibility when we are designing low-calorie diet plans. So if we design in a way that economical feasible and the individual preferences, we can have more adherence towards our dietary guidelines. Therefore, we think of
some economical feasible approach for the low-calorie meal replacement. That is why we have selected pumpkin as a low-calorie meal replacement in our weight loss management strategy. Why is pumpkin special? Ongoing availability in the Sri Lankan market, and it has low calorie content with higher fiber content. It is a nutrient-dense vegetables with hypoglycemic effect, and also it has anti-inflammatory and antiviral properties. It has significant content of carotenoids, tocopherols and antioxidants. In this table you can see the nutrition composition of pumpkin as well. With this backdrop, our objectives were to investigate whether dinner meal replacement with a low-calorie pumpkin soup is an effective strategy to lose weight in overweight or obese adults, and also to evaluate the effects of low-calorie pumpkin soup on body fat levels, visceral adiposity and fasting serum lipid of adults. For this study, we conducted it as a randomized controlled parallel intervention trial. We conducted our study for 8 weeks duration. We initially screened 55 participants, and there were 50 eligible participants for our study, and there were 6 dropouts. And finally, we came up with 41 participants for our study. We divided them into as intervention group and the control group. Intervention group, both intervention group and the control group were given same dietary guidelines, but intervention group only provided with the pumpkin soup as their dinner replacement, and control group was not given this meal replacement. You can see here the inclusion and exclusion criteria of our study. We included 20 to 60 years adults within the over the BMI of 23 kg per square meter, and they were free of any other chronic diseases as well. We excluded all the clients or the individuals who had the chronic diseases and pregnant and lactating mothers. So this was the dietary guideline booklet that we provided for all our study participants, which included into the control group and the intervention group. This is how we made the pumpkin soups. We took the 250 gram portion of pumpkin and made it as a soup, as you can see in this slide. And we gave it for the intervention group to take there as a dinner meal for 4 days per week for 8 weeks. Then in this table you can see how we assess or collect the information throughout this study period. During the enrollment we did the initial screening and we obtained the consent, and at visit 1 we did the baseline assessment including the anthropometric body composition parameters, as well as we assessed the blood pressure and the pulse wave velocity, and also their blood glucose levels and the lipid profiles. And at visit 2 and the visit 3 also we took the same measurements. So this is how that this picture shows you the data collection procedures, how we collected the data and how we assess their blood parameters using our biochemical analyzer. Let me show you the most important part of our study, the study findings. As you can see here in this table, at baseline level, there were no any significant difference between the intervention group and the control group according to their age, BMI and the body composition parameters, and also their biochemical parameters. So most importantly, you can see here that intervention group had shown a significant weight reduction after the 8 weeks compared to the control groups. There was around 3 kilos of weight loss achieved within the intervention group compared to the control groups after the 8 weeks of this study duration period. And this graph shows you how their body composition parameters and biochemical parameters change during these 8 weeks of period. So you can clearly see that there was a significant reduction in the body fat mass and also the visceral fat level within the intervention group compared to the control group. And also the intervention group had a significant loss of total cholesterol levels and the LDL cholesterol levels compared to the control group. Not only that, we assessed their arterial stiffness using the blood pressure monitor, and it also shows that there was a significant reduction in the arterial stiffness in the intervention group compared to the control group. With these findings, we would like to conclude there was a significant change in the weight reduction in the intervention group compared to the control group. So, and also our study findings shows that there was a considerable reduction in body fat levels, visceral adiposity and the fasting lipid levels among the intervention group compared to the control group. So with this, I would like to conclude my presentation giving you a message that if we can think of some novel approaches rather than going always with our usual patterns, we can achieve some significant outcomes from our participants. So I would like to acknowledge these people who helped for our study. Thank you all of you, and my presentation is now open for the discussion.
Thank you, Dilki, for your nice presentation. So, any questions from the audience? Yeah.
No, sir. They had only the pumpkin soup. We gave only the pumpkin soup. Yeah, because we took their dietary information throughout this 8-week period, and we make sure that they didn't take any other meals with that. They took only the pumpkin soup.
So I think if you can increase the protein content in that, it's better, because to be weight maintenance we need more proteins, because when you are continuing like this, so it's better if you can add something and increase the protein content.
Yes, ma'am. So that's a good idea. Thank you very much.
Yes. Special mic.
I mean, these might be very simple questions, but what about the diet history for the rest of the day and the physical activity levels of the control and the intervention group?
So we didn't do any specific dietary modifications apart from the meal that we gave them as a meal replacements. We generally ask them to, both groups, we ask them to cut down on excess the high sugar content foods and the fatty foods. Other than that, we didn't, for the both group, we didn't do any other specific modifications. We did only the modification only for that meal replacement.
It will be very interesting if you can, this is a very good study, if you can tighten up the rest of the day, the diet history, physical activity, and the thing is, psychologically, if the control group knew that you were doing this study, they could also just, mentally, sync themselves to reduce anyway.
Yeah.
So, or to, the other way around.
Yes.
So if you can do a really tight study on this type of thing, not only pumpkin soup, I think you'll have a complete, a more user-friendly kind of a study.
Yeah, thank you, ma'am.
Thank you, Dilki, for your nice presentation. And so we are now at the end of today's pre-paper sessions. So there were 7 presentations. So many congratulations all the young, the budding scientists for their presentations, and all the audience for the productive discussions. So thank you very much. So.
Thank you everyone for enlightening the audience with interesting topics. Now let's move on to the final session of today's event. We at Nutrition Society of Sri Lanka do not forget our roots, the founders of the society. So it's now time for the Professor T.W. Vikramanayaka oration. Please rise as the procession arrives. So the session is now breaking up for a tea break. We'll start in 5 minutes.